Hello and welcome to Mental Health TV. This is our second episode. My name is Nikki Lambert. I'd like to introduce you to my other colleagues here. So Vanessa.
Hi, I'm Vanessa Garrity. I'm presenting tonight with Nikki, but I'm also going to be looking at the social media comments when they come in. So if you'd like to join us, you can either join in on Twitter, hashtag MHTV, or you can join us via the Facebook live feed. And we'd love it if you could send in some questions for Rebecca this evening. Thank you.
It's fantastic. We've got Dave lurking in the background, but can we also bring in our fantastic guest, Rebecca? Can you tell us a little bit about yourself?
Hi, yes, I'm Rebecca. Rebecca Thomas. I'm the HSJ's Senior Correspondent for Mental Health, Learning Disabilities and Autism Services. What to tell you about myself? I'm interested in all of the above. I think I'm particularly interested in issues of patient safety within mental health, LD and autism services, and more recently, health inequalities.
Yes, thank you ever so much for taking time to be with us. It's really much appreciated. And I'm sure loads of people will have questions for you, but we have some questions for you as well. And the way we'll do it, obviously, is we'll ask you some questions and then we'll go out to people who are listening and see if they want to join in too. So the thing I think that we were first thinking about was, this is the year of the nurse and the midwife. And it's absolutely not what we planned. So
or anybody planned.
So, globally speaking, there were all these activities we were going to be doing to bring nursing, particularly, into the forefront. And for whatever reasons, and there are many, not least of which being COVID and coronavirus, none of those plans have really taken place. So what would the story have been this year, do you think? The big stories in mental health have been if we hadn't been talking about coronavirus.
We hadn't been talking about coronavirus. Well, how to recruit more nurses, how to retain more nurses, and I think, to be honest, I think that's still going to be the issue we need to talk about during coronavirus. But I think this was going to be the first year of the long-term plan, and so recruiting now, so to make the service changes later, was going to be the biggest thing to talk about.
So staffing. Yeah, I could see that. What impact do you think coronavirus is going to have on staffing?
There's been a lot of debate about it. So whether this further down the line we'll see staff suffering a lot of PTSD, whether what do they need now, whether it's the usual day-to-day stuff like a normal rota, more pastoral support. So I think maybe we'll start to see employers and the public finally thinking about the well-being of NHS staff and in terms of what they're going to need, because they are what has kept things running during coronavirus.
Absolutely. Vanessa, did you want to comment at all on staffing or impacts of corona on that?
Yeah, no, I'm just interested, just in terms of all the things that have been put in place to bring nurses back, nurses who've retired or left the profession. It'd be just interesting to know whether any of those nurses or how many of those nurses will continue now they're back in nursing. How many were we successful in bringing back and what's been their experiences? And that'd be quite interesting, because we've been talking for a long time, haven't we, about how do we recruit people, how do we bring people back, but it took a crisis for us to suddenly think, well, we can be flexible about an MC, we can be flexible about kind of return to nursing training. We've somehow managed to get a workforce together who's been able to get people through return to nursing and back out there quite quickly, and we couldn't do that pre-COVID. So I think there's a lot of learning from that, but also be quite an interesting thing to focus on after the pandemic. So I've been looking.
So do you think the profession will have become more attractive after this?
I don't know. I mean, it's difficult to say, isn't it? I mean, people are putting their lives on the line, aren't they, at the moment? And I think I was reading a comment that said, a nurse who said, they'll always remember this. If anyone says, what were you doing during the pandemic? They'll be proud to remember that they were a nurse during the pandemic. And I can totally see that, but I can also see how much trauma nurses have been through, how many families have been separated during the pandemic, mothers who are nurses who've been separated from the children for weeks because they don't want to put them at risk. other colleagues I know who've lost people during the pandemic. So I think it'll be really mixed, really, in terms of the impact. I think it's raised the profile, hasn't it, quite rightly, away from talking about bankers, actually talking about people who are making a difference to other people's lives, and maybe will value nurses and healthcare staff differently in the future. I'd like to think so, but we'll see. I mean, what's your thoughts, Rebecca? Do you have any thoughts on that?
Oh, well, I'm not a nurse, so it's difficult to say, but I think it's definitely raised the profile in terms of you've got the whole public clapping for those who work in the NHS every week. But then I think also at the same time, there's that unhelpful, and we were discussing this earlier, that unhelpful mantra about being on the front line, as if it was signing up to join the army, which I don't know, personally, I think is probably an unhelpful comparison.
We've always had a history of it, haven't we? With people talking about, cancer survivors, people talking about battle and war metaphors when it comes to illness. And now it's sort of spread into staffing. What I particularly have a problem with about it is that it suggests that becoming a nurse should mean that, as a matter of course, your life is put at risk. And this, I think Vanessa as well was talking about kind of a hero narrative, where if somebody is a hero, they're doing it because it's expected. And things like safety, security, respect, those things are bound up together, when actually you can respect someone, you can clap them, and you can pay them, and you can protect them. They're not either or. They're all different aspects of the same working environment, I would say. Was anything coming through on Twitter?
Just an interesting question from JJ Slater, who says, I'm interested in what Rebecca thinks with regard to the current inclusion of learning disability, autism deaths in the COVID numbers, and why the inclusion took. So I know we were going to that anyway, but Rebecca, any thoughts now?
Yeah, so it was really important that data was published, and it should never have had to been dragged out of the government and NHS England. And the reason why it was important, because it can flag up issues early, so they can be dealt with now instead of next year and next year's leader report. There are a lot of problems with the data in terms of the way they're recording it, and there probably are thousands of people that aren't actually being captured by it. So, for example, the mental health one is the category is people who have been treated by mental health services at any point in their lives. So that's very nondescript. But yeah, it was really important, and we need that kind of data to even get a hint at whether things like what happened with the DNRs at the beginning of this have had an impact.
Yeah. So what Rebecca's referring to there with DNRs, do not resuscitate. And at the start of the COVID pandemic, people with learning disability and people with autism there was concerns they would be denied intensive care treatment if they became ill from COVID, because they were being wrongly categorised alongside elderly or frail patients. And now I have a problem with all of that. So, people who are elderly and frail being given automatic DNRs anyway, I think is should politely say extremely problematic. But this idea about lumping in completely different types of client, and also when you say types of client, you're kind of missing the point that they're people, types of people.
Not service users, they are people.
Yeah, people, yeah. And this idea that you would have an automatic expectation on how they will be treated in an emergency, I found quite frightening and quite concerning, and rightly there was an outcry over it. So the current situation, as far as I'm aware, is that people are saying that there isn't any unusual activity in the numbers around a learning disability, but it's not counting private homes, am I right? It's not counting a lot of places where we know this population live. So CQC are going to analyse the data, but we will yet to see.
There was quite a significant number in leaders. So the leader published their data after, or NHS England published leaders' data after much pushing, and it shows you non-COVID deaths, and there has been quite a significant increase in deaths of people with learning disabilities and autism not from COVID, and that as with the excess care home deaths, that definitely needs to be looked at.
absolutely. Because I mean, this is a problem without a solution at the moment, isn't it? So we don't know how many waves of this we're going to get. We don't know if this is the first of other very similar experiences that we're going to have. So the sooner we get on board with recording deaths in a way that helps us to understand what's actually happening, what the picture is, the safer people will be overall. But it shows up the fault lines in society, doesn't it, around power so clearly.
As I understand it, there is a big problem with just general the recording of people who have autism. And as I understand it, there is a big black hole in terms of that.
Can you tell us a little bit why you think that is?
It's difficult. I'm not sure. Perhaps not a priority, doesn't fit into a certain slots, not conditioned to be treated. I don't know.
One to watch, I think, there. So in terms of kind of the experience that people have had, we also mentioned, like last week, we talked about this idea that, it's the same storm, but different boats, different people are having very different experiences. So can you tell us a little bit more about kind of the inequalities that we're seeing, anything around sort of data and missing things that we need to look at more closely as professionals?
So, and I'm not sure of the data this is based on. I think it's mainly based on surveys by charities such as Mind and Rethink, but PHE in a presentation last week to people in the service. So that basically they highlighted that people with serious mental health conditions were recording much lower levels of well-being compared to the general population. And I guess if you think about it, that needs to be a group of people we really should be having a focused eye on because of all the health comorbidities that come with that population and the fact that there are these huge health inequalities. And off the top of my head, I don't know what the rate is, but it's much lower life expectancy, for example.
Yeah, absolutely. Vanessa?
I was just going to say, I know that Rethink have been doing a survey as well, looking at, surveying people who've got sort of serious mental illness and the impact on COVID. So it'll be quite interesting, that I think, in a future episode, perhaps, because certainly talking to my colleagues who are working with that group, it's very, very difficult, and presentations of people are different, and certain inequality and people being isolated and people with serious mental illness might not necessarily have the devices or digital literacy, but are not seeing mental health professionals regularly currently, or a lot of their experiences of psychosis are kind of becoming linked into coronavirus. And I guess being a nurse and not being able to have that connection with people at the moment is quite difficult, because that's kind of what we do as mental health nurses, isn't it?
I do have some data on that. So I had, again, PHE, so Public Health England. So 1 in 4 adults have not received the mental health care they need during the pandemic. People with serious illnesses are reporting much lower levels of well-being compared to others. So we can see really clearly that this is changing how people are being able to access care. And it's difficult, isn't it? Because on one hand, as soon as we all went online, I think some people thought that would bring an equality in itself. Like everybody used to have a phone, everybody has a mobile pretty much, everybody pretty much has access. And now we're seeing actually that's not true. So there has been some real inequalities on that.
Yeah, I think it's something that really should be watched because I don't know what do you call it, internet inequality. People able to access, people being digitally literate, and whether that might cause additional inequalities, because as we know, most mental health services have continued to provide services throughout COVID-19, but largely digitally.
Absolutely. It's been interesting as well, hasn't it? Because a lot of the kind of story has been around how adult nursing is stepping up, and adult nursing has done a fantastic job. But I think it's really overlooked the fact that mental health services have carried on going. People have reorganised trusts, people have worked across boundaries, borders. They've come in from home, they've stayed isolated from families, they've moved client groups around to keep people safe. So much work has gone on across the whole of the NHS and other sort of social care facilities. I think a lot of that has been unseen. But what has been interesting as well is this, now we've had this digital disruption, we've had this big break. I mean, from an education point of view, people were talking about doing stuff over the course of 2 or 3 years, and actually it happened over the course of pretty much a long weekend. So it didn't happen smoothly, but we did sort of lump our way into online learning very quickly. And I think one of the things that's interesting is how service users are being able to access sort of GP appointments now. I've had colleagues who've had sore throats and have been putting like their mobile phones in their mouth so their doctors can have a look down the back of their throat. So we are seeing really new ways of working. But again, we have this big issue with internet access is not a given for a lot of people. Privacy, and so if someone's in an overcrowded or shared accommodation, they don't necessarily have anywhere private to have a conversation. And it's great, isn't it, to be able to access therapy or an intervention in your car, just be able to have a quiet time. But at the same time, it is leaving people very open and exposed in other ways. Vanessa, did you want to come on that?
Yeah, I think really illiterate and do have access to the devices. If you're pressed or you're hearing voices, you might not necessarily want to have a conversation. I mean, I know myself, just doing a few work meetings on Zoom can be absolutely exhausting. And I love digital technology. So if you're thinking about somebody who's unwell, who's lacking confidence or experiencing paranoid thoughts, and then we're asking them to go online, or even just somebody who's feeling depressed, ringing a GP at the moment, and the length of time it's kind of taking to get through, and feeling like you're not really a priority because you're aware that we're in the middle of a massive physical pandemic. And so people, I can imagine, not wanting to come forward about mental health issues at the moment as well. So I think I think it's quite complex.
Do you think it could, so people are online all day, for example, working all day on Zoom calls. Do you think that can make digital consultations less of a safe space, for example, because you're online all the time?
Yeah,
maybe.
Quite really, because I think pre-COVID-19, for example, see some brilliant aspects of having a digital consultation, particularly if you're working and you're managing a long-term condition and you want to just have a chat with a doctor before you go to work or when you get home, or you want to use a digital device to sort of self-manage your condition. But then obviously at the other extreme, there are all the issues that we've just talked about. And so I think it's a complex picture, isn't it? It's not a kind of blanket one size fits all, but I do think there is an opportunity, isn't there, post-COVID, to kind of reflect on how we've suddenly all managed to get much more kind of digitally literate as a professional group. As before, there was so much kind of anxiety and governance kind of barriers and
cut the bureaucracy out the system.
Put all that out now, and now everybody's using Zoom and everybody is having WhatsApp consultations, or it might be being a bit flippant, but generally the number of online consultations, and even the way we've used technology for other things as well, and the way kind of private companies have worked with the NHS, to get some of the equipment in place in the Nightingale wards, for example, that would usually have taken years and years, and has managed to be approved as a medical device within weeks. We've got to take some of that and think about how we can be leaner in the future, I think.
It has galvanized people working together, hasn't it, across sectors?
I think it did initially, but my feeling is that that's starting to change a little bit now. People realise we're in it for the long game and we need to think about where we go next. What I do think is exciting is the fact that, again, the biggest champions for service user rights have been the charity, the service user-led charities. And I think, it's a real lesson for nurses. I'm not saying that everybody should do everything and nurses should be completely leading this, but I think nurses should be absolutely tipping their hats to people like Rethink and people who constantly, day in, day out, put service user rights front and square and follow up on everything. Yeah. And I think I would love to see nurses supporting a lot better those charities and that kind of work, and feeling a bit more confident to say when something isn't right. challenge stuff a little bit more. I mean, to be honest, it was such a quick situation that it was as much as we could do, I think, just to get through it. But now we're sort of learning lessons. I think there's a lot to be learned. I also love the idea that technology puts information back into service users' hands as well. This idea about self-recording, recording how you're feeling and actually uploading it. So rather than having somebody come around chasing you and talking through the letterbox and trying to get you to comment to them, actually in your own time, because people are busy. Service users have lives. They don't just sit around waiting for staff to fit in a visit. This idea that actually people can just upload how they're feeling, how they're doing, and they can, almost do surveys and send it back. All that kind of stuff just puts information back in the hands of the people that it should belong to. I think that's exciting. It's a chance, isn't it, a disruption to do something differently.
It's a good point about the charities. One of my colleagues did a story a couple of weeks ago about how fragile financially charities are during this pandemic. I remember Beat, for example, said it was a massive risk to their helpline, and you realise how much the voluntary sector actually does. So I think it goes beyond nurses, and I think the NHS as a service will have realised how important it is to support and engage voluntary sector.
Did you have anything, Vanessa, from social media, or should we press on?
Yeah, we've got a couple.
You're breaking up a little bit.
Mike, can you hear me? I've got a comment here. I'm interested in what the panel think might reduce the inequalities you've been referencing. For example, NHSI and NHS England have both published standards indicating that all NHS staff should receive learning disability, autism and mental health training to reduce inequality. But this doesn't seem to happen. I mean, that's a really good point, isn't it?
Yeah. A really good point, and that was Oliver McGowan's legacy, and his mother, Paula McGowan, has done some really good, really amazing work in pushing that. I don't know where the government has got to in that training scheme. It was meant to be launched this year and meant to be rolled out. But yeah, it's a very good point. It's really important not to lose sight of things like that, and training across the whole sector, not just mental health services, in understanding learning disability and autism.
Yeah. Well, with the new nursing curriculum, that is supposed to be in there, so we'll see, won't we? But I think it's if there's anybody out there who wants to develop that stuff, put it online, I think everyone will snap it up, because people are desperate to have that input, and we've lost a lot of space and time in making sure we're on top of this, because we've lost a lot of learning disability nurses and not replaced them. And I think that absolutely is fundamental. If you don't have a professional specialism who care about this first and most, and push it and make sure that it's represented, you start to see things slipping. I think it's really important as well. One of the things that mental health nursing needs to think about is how we stay front and centre, how we stay relevant, how we stay talking about the issues that are important. We've been talking about mental health crises for the population. I hear psychologists, I hear doctors talking about it. You don't hear so many mental health nurses getting up and commenting on mental health issues. So I think it's really an exciting opportunity to see when those nurse voices are tapped, what they have to say.
Yeah, definitely. So I've found this a lot throughout my work. I find nurses sometimes find it more difficult to, go on the record with something than a medic or a senior manager, and I do wonder why that is sometimes. For obvious reasons, I think there is obviously that fear there, but it's so important.
And what do you think the fear is?
I don't know, perhaps the fear that they're expendable when they're really not. I know.
Well, I think that's a good point. One of the things I think that I first felt when I was trained to be a nurse, that's 20 years ago, I was very much given the messages that a good nurse is someone who is quiet and compliant and works as a team member and doesn't stand out and doesn't raise their head above the parapet. And, if you have a complaint, to make it through the right channels, and I don't think anyone ever explicitly said to me, you shouldn't be political. But, you look around at the situation and it's nothing but politics all the way through health. And there comes a point where you actually have to remember that part of your job is patient safety and advocacy, and that requires you to stand up sometimes and say stuff that maybe people aren't too keen to hear, or ask for figures, as you did, that people aren't too keen to share.
Or shout, rather.
Yeah, absolutely. Vanessa, what do you think? What do you think about nurses and sort of finding a sort of voice or a political voice?
I think similar to you, Nikki, that a lot of nurses believe that they can't be political and they can't have a voice, that somehow it will get them into trouble and that we have to stay neutral. But I think there is a sea change, I think, with the current government and the things that are happening politically at the moment. I'm seeing far more people kind of expressing their views, particularly, you know, with things that have been going on in the last week over social isolation. I've seen a lot more people talking about it online than they would have done before. So I think we are becoming more political, but I still think, like Nikki says, that there's a reluctance, and certainly, you know, if you work for some NHS organisations, there's an expectation that that you don't be political. That kind of, like Nikki says, quiet and neutral. But I think, for me, that's difficult as a mental health nurse for the reason that Nikki says, because I think if you look at the history of mental health nursing, in terms of, you know, what we did to people and how paternalistic we were as a profession, I think we've got to kind of drive forward the sort of advocacy and speaking out about inequalities that people are experiencing. Otherwise, we're never going to move forward. So I think that mental health nurses are possibly in a position where they need to be more political because of the nature of mental health. But I think all nurses should be political.
And for me, I'm talking sort of small p political. I mean, because obviously a person's politics are their own business, but there is something sometimes to be said about inequalities that's for everybody to comment on. I can remember the first time I actually said something or got quoted saying something political, and I was so scared. I don't know who I thought I was going to get into trouble with. I was really terrified. I thought somebody was going to tell me off, and it was probably only about 5 years ago, which is when I think back on the things that happened during the last 15 years before that. I should have said a lot more. I was at a conference and I was presenting some stuff on violence against women, and somebody from the audience was saying something about you know, shouldn't this isn't a social issue, this is a medical issue, this is a medical conference, why are you talking about it? And I said, you know, all the Prozac in the world is not going to stop someone getting punched in the face. We need proper laws, we need places for people to go, we need for nurses to be asking the question, are you safe in your house? And somebody basically wrote down what I said verbatim and put it on Twitter. And I was like, oh no, now everyone's going to find out. And I was like, why did I go to an international conference if I didn't think that was the right thing to say? You know, and you suddenly have to realize that actually looking after people and looking out for people and serving people requires you sometimes just to say no. And a lot of nursing, I think, is about us wanting to be liked. You know, and our power comes from people liking us. But I think sometimes the reason people like nurses is because they can project whatever they want onto us. You know, compliant, polite, sweet, compassionate, caring. And I think nurses have all those capacities, but they also should have the capacity to say no and to stand up and defend somebody when they're not able to defend themselves. You know, and I think that's just, you know, people don't want to see the strength in nursing. They don't want to see the intellectual side of nursing sometimes, and that makes me really frustrated. You know, that kind of like too posh to wash, too clever to care. It's like everybody would want to be reasonably clever and reasonably caring. They don't have to pick. It's a false choice.
Can be both.
So there's something to be said about pushing back a little bit on that nursing image.
Journalists don't have that problem. No one likes journalists. So all right to be hated.
It is a very weird thing, though, isn't it? Because it's all perception. None of it's real. It's just about what the public imagine. Yeah. So we were talking about inequalities before, and I think this is, you know, a really prime time perhaps to talk about kind of inequalities in staffing as well. And one of the things that's been really clear is that staff from Black and Asian minority backgrounds have had much higher death rate and much higher infection rate than other members of staff have had. Can we talk a little bit about that? What's going on? How we're counting it? What's happening? Why this is happening?
Yeah, well, to be honest, I think it throws up more questions than
That's
anything
great.
else.
We love questions.
Sorry for the politician's answer there. I think in terms of what hospitals and trusts are having to think about now, I think they're going to have to think about, first of all, for example, if you risk assess your entire BAME staff population and find out that they're all at risk, are you going to take the entire group off the front line because services would, quite frankly, collapse? But then what is the balance? And then, for example, do we need to have a specific support in each trust for, mental health support for BAME staff? Those are kind of things that we need to be thinking about right now because the research isn't there yet. We don't actually know what it is, what the risks are.
Vanessa?
Yeah, can I just come in with a question we've got on social media? And that's a lot of mental health services, because I think it's really important. A lot of mental health services have been restructured due to the pandemic response. Some have been closed, and this has had consequences, such as increasing the threshold for admissions. In the panel's opinion, what will it take to reverse these changes? Do we think COVID is going to be a requirement for admissions in the foreseeable future? We think about the reality of patients who are positive, acutely unwell as a standard practice on wards into the medium and long term. So I think there's about 3 questions there. So obviously one about restructuring. The first one was about restructuring of services and a lot of services closing and the effect that that's having and the impact that's having on thresholds for admission as well. And then the other one is about kind of what will it take to reverse those changes, and then just about kind of managing COVID really in mental health settings, segregating people who are testing positive but might not necessarily be unwell, and the potential for that to go on for quite a long time as well. So
I guess taking the first one, the restructuring, slightly more, I guess in a slightly more positive angle, these mental health A&Es that are popping up, it will be interesting to see what happens with those in the next few months. I mean, whether they are a good thing, whether they turn out to be a good thing. Just to explain, during COVID, quite a few mental health trusts they weren't pop-ups. They launched A&Es for people to avoid people going to acute A&Es. Now, obviously, these can only be used by people who don't need physical healthcare. It will be interesting to see because it, on the one hand, it does sort of separate mental health and physical healthcare further. If you look at it that way. I don't have the historical knowledge to know if we've had anything similar. I don't know either.
Yeah, we had emergency clinics back in the day at the Maudsley. So it was 20 odd years ago, something like that. And they were interesting places. So the Maudsley emergency clinic was opposite the King's A&E department. So you actually could either turn left or turn right, depending on what your major issues were. But there was lots of reasons that it closed down, I think, not least because it was actually quite a feisty place to be working, very politely say. But we also have suites now. We have admission suites, so we have lots of different ways of working that. But it's a really interesting. It just goes to show you in health, nothing ever goes away. You just put the paperwork to rest, and then it pops back up again in
big circle.
Yeah, absolutely. So A&Es. What else were you going to draw on? It's interesting.
Well, I was going to say in terms of restructuring, a lot of trusts will have had to inevitably restructure their wards, close some wards because of managing COVID. I did a story a couple of weeks ago with RC Sykes' eating disorder lead, who said inevitably capacity in inpatient services in that sector has had to be reduced. So to manage infection. And I guess that links into the second question about whether thresholds.
Yeah.
And I think sadly, trusts will have to manage an occupancy rate. Some trusts right now are at occupancy levels they haven't seen for ages, so 60, 80%. And we know in mental health that that doesn't ever happen, really. And I think the only way to manage that and manage a second peak will then be the increasing thresholds, sadly.
Yeah. But it's the same as we're seeing in adult nursing, isn't it? In that everything that's a massive emergency is getting seen. So heart attacks and sort of like psychotic breakdowns, things like that are being seen as an emergency. It's the long-term sort of chronic illnesses that people experience that kind of like heartbreaking long-term things like cancer care for adults, things like long-term depression and anxiety for mental health services that are being told they can wait. So I think we're going to get quite a bit of a backlog forming. That's a worry.
Yeah, that'll be the spike in the tail, won't it? Particularly if there is an additional surge in mental health need, as all the services are predicting there might be.
Melissa?
Yeah, I was just thinking of that whole issue about thresholds. So, to get an acute bed, obviously, you'd have to be very unwell at the moment. But equally, people who are managing at home at the moment, it's a completely different.
You're frozen.
Picture and managing it. Yeah, because you're not going to be seeing your family. You're not necessarily going to be seeing any professionals at the moment. That connection's not going to be there. So people are going to be much more isolated than they were before. So I think it's very difficult, and it's not something that people are talking about, really, is it? Because I'm not sure why that is. I don't know if it's because we're so focused on obviously the physical crisis of the pandemic, and obviously the health pictures just starting to emerge, but the mental health picture is going to be an issue, isn't it, for a long time? And I think that comment there is really interesting about segregating people in mental health wards who are positive but not displaying any symptoms, and how long that's going to continue. And given all the work that we've done around sort of and restrictive practice and things, and then we're moving into a position of having to segregate people. It's very, very difficult position to be in for the person who's been segregated, but also for the mental health staff as well. So I don't think mine's a question, really. I'm just reflecting on it, really.
Well, it undermines a lot of the work that we finally started to get done around sexual safety, didn't it? So for a long time, we've had this real need to make sure that people don't come to harm, particularly sexual harm, in our inpatient settings. And now, if we're going to be dividing, segregating or moving people around on a completely different criteria, that work will be taking a back seat again. So it's going to be a challenging time for all the people that pull together to really start to drive that practice forward.
Yeah,
ongoing work.
I do wonder if it's and I haven't been on a ward, but if it's less possible for staff and patients to be interacting on a ward because of COVID and because of the infection risks, whether things like the sexual safety issue, so that will go even more unnoticed. Would there be a risk around that? There's so many things that, for example, dormitory wards, all the promises that we need to get rid of those this year, are very unlikely that that's going to happen now, and it will be even more difficult to tackle that with COVID-19 within wards. There's an interesting thing you said about focusing on the physical healthcare aspects, because I was thinking about the shielded group, so the 2.2 million people that are having to be shielded, and not much has been said from the government or NHS England service about the mental health needs of that population, because I imagine how hard it must be to be indefinitely told that you're going to be at home, not able to go, isolate, and the risk to your life.
I think as well the lack of clarity has been quite frightening for people, and the fact that as soon as people get their head around what they're supposed to be doing, there is a feeling that people are quite confused sometimes about what they are supposed to be doing, what they're not supposed to be doing. And with any kind of news cycle, it's all about the throughput, isn't it? It's all about being dramatic, focusing on things that are frightening or scary, and that has not served us well, I think, in terms of well-being for people. So there's a lot to be said around kind of public mental health and being a lot more mindful of that. And it can change. Just think about how suicide reporting changed and how people challenge media representations of mental health. That stuff changes all the time. You can make things different if you just speak up about them.
I mean, one of the areas that nobody's speaking up about is prisons as well at the moment. Dire situation in prisons, because a lot of prisoners are, restricted to their cells at the moment. So we know that self-harm rates are going up in prisons. We know that mental health staff often aren't able to go and see people face-to-face or offering support. So, in terms of a mental health crisis, it's massive, isn't it, within prisons, and where so much inequality as well. So I guess, what's happening in the mental health world generally, but then I think it's at a different level again if prisons for people. And when you think that a lot of people in prisons are victims, and potentially shouldn't be in prison, people who've committed minor offences, although I do know that pregnant women, for example, some have been let out on licence rather than staying in prison. But to me, that begs the question that if we can do that during a pandemic and those people aren't considered a risk to the general public, then why can't we look at alternatives outside of the pandemic to send pregnant women to prison? So that's an issue. We've got some more questions as well that have just come through. So I think the question about inpatient mental health seems to have generated. Yeah. So one is a really good question actually about the changes to the Mental Health Act. So we know that changes were brought in with the Mental Health Act legislation. So instead of somebody needing to be assessed for mental health detention by two approved doctors, currently be detained under the Mental Health Act with one doctor. So the issue is about what we think about that.
So as far as I'm aware, they've not been triggered yet. And I say yet because we don't know if they will be triggered. It all depends on whether the services are incredibly under pressure. I guess there is that worry that because they were even mentioned and within the Act, whether in some places it's already being done. And the importance, I think, it is being monitored, or at least the DH have asked trusts to report to them when they've had problems with the Mental Health Act and getting Section 12 doctors' naps.
I think for me, it brings me back to his point earlier about advocacy and nursing. So I can totally see that whilst this isn't great, a pragmatic decision, if we don't have enough doctors, then we may have to make changes to the legislation. But that doesn't mean that we won't be kind of still able to advocate for somebody. So if somebody comes into hospital in that context and as a registered nurse on the ward, I still think that as a nurse we've got a responsibility to advocate for that person if we think that they've been unlawfully detained. So I think that's kind of what that I would reinforce, that it's more important than ever that we as a profession are making sure that people understand the rights, and if we feel that someone's unlawfully detained, that we're able to speak out and support people to appeal against detention. Whilst also understanding that this has been done as a sort of pragmatic response to the crisis, in my opinion, rather than to kind of detain people in the future with only one doctor and kind of reduce the sort of ethical framework that we've got in place currently. So there's that question. And then someone's put as well, do you think it'll be more challenging to meet community service needs over the next 6 to 12 months, or inpatient needs in a COVID environment? That's interesting. So I guess that's about the challenges in the community mental health setting versus the challenges in an inpatient setting. I mean, personally, I think that they'll both be different challenges.
Yeah, definitely. I mean, so this was meant to be the year we started to rebuild community mental health teams. As this was supposed to be the year that we started to bolster those services again after years and years of having funding cut and resources being cut. So that hasn't happened yet, and COVID could very well take the focus away from that, which will be a disaster. But I guess if we're thinking about mental health needs, it could refocus the need to bolster community mental health teams. And we were talking about thresholds earlier. How do you deal with thresholds in your community mental health team, for example?
There's a lot more emphasis, I think, going to be placed on sort of non-medical responses, I think, to stress and anxiety and distress. And I find that quite positive. I think it'd be really good rebalancing back out again. So if you look at who stepped up and who stepped in, you look at the community support services that have come from within communities. That's been amazing to see. People checking in on each other. That's been amazing to see. It's not the public's job to deal with serious mental health issues, but I think it is our job as people to be nicer to each other. It's much underrated. Like just halfway decent.
Well, you look at the volunteer scheme and the thousands and thousands of people that signed up to it. I mean, I don't know what's happening with the scheme now, but
we'll see. Well, I do think we're also going to see a lot of stuff that started just getting quietly shelved. So we had great movement forward on supporting people who were homeless, people without homes. All of a sudden, we found ways to solve that problem. And now it's slightly dripping back. It's just going back again now. We found ways to step up and actually give power to other people. So we should be keeping that. There's a lot of things that COVID has caused, like big shifts in attitudes and what we thought was possible. But I think we do need to keep a real close eye on where we're going to. And so for me, the biggest thing about the Mental Health Act changes were, I just didn't know they were happening until I saw them on Twitter. I mean, I do keep an eye on what's going on, and I think all sort of people with mental health interests should really keep an eye on what's going on, just so they can make sure they input into it. But it was such a swift thing. I was like, oh, I suppose that makes sense. I guess what's happening. It felt very much like that, rather than like this is a safety issue and it will be over or be under review to be taken out by such and such a time. It felt like it was something that kind of slipped in without much discussion. It was and
a lot of grey around it. I think so. They only recently some guidance was published around digital assessments and the legality with digital mental health assessments. As I understand it, the guidance from NHS was legally we can't see anything wrong with them, but essentially that will have to stand up if it goes to court. Yeah,
which makes it very unfortunate for the person who has to test that out, doesn't it?
Yeah.
Absolutely. Is there any more questions, or should we press on? Because we're running out of time now, so we just do a couple more.
Just one here, which I think is quite interesting. Does the panel have any experience or knowledge of peer advocacy for mental health and learning being done remotely at the moment? How can peers, to use the term in the community, advocate for inpatients without physically visiting wards at the moment? So I guess the question is, are we aware of anywhere where that's happening? That's by Mad Lives Matter.
That's a really good question, and I'll have to be honest, I don't know off the top of my head if that's happening anywhere. I guess it would be for trust to actually go out and say we're enabling that here, so please come and talk to us. We want your help. We really want to encourage peer advocacy. So perhaps
some real issues, haven't we? I can think of loads of trusts that don't even have proper Wi-Fi. So how somebody would be able to use their phone. And also, I can remember times when phones were used to be taken off people when they came into hospital, and that's like unthinkable now. It's really challenging. I know it happens from time to time, but absolutely it should be really, really questioned if that's a situation, because it's somebody's connection, isn't it? It's like taking away everything from somebody. So there's something around how people are negotiating online. There is some fantastic practice, not particularly around advocacy, but I've seen the Dragon Cafe has gone online. There's a lot of service user groups that are moving forward. I know recovery colleges have gone all online now. So I think it's going to be a matter of time before that boundary is broken forever. This idea that somebody, a gatekeeper, can control what goes on a ward like that. In the past, absolutely, staff contained people, whereas that's not possible now, and nor should it be. That will always be a porous experience from now on, and that will be changed forever. We can't go back now, and I think that's for the best. And there's no reason why an advocate shouldn't be able to comment in a ward round virtually exactly the same way a social worker or an occupational therapist or anybody else should.
Absolutely. Mm.
For just finishing up, we were looking at if somebody does want to sort of start speaking up or speaking out about issues that concern them, have you got any sort of like top tips, any things that you would suggest that people would consider?
Speaking to a journalist you trust first. I mean, journalists get a bad rep, but the ones I know they're all very trustworthy and will protect a source to no end.
So it depends who you're speaking to then, what journal?
Depends what you're speaking to, yeah. I mean, there are so many different forums there to speak up and speak out. I mean, you can speak out to trusts directly, I would say sometimes as well. Don't be afraid to challenge things that you are seeing come out of your trust, even if it's on Twitter, even if it's to be challenged on Twitter.
I think one thing to just be aware of is as for any health professional or any student, if you're putting stuff on Twitter, be aware that it's in the public domain, so it can be quoted in newspapers. It can be, that information can be moved out of the context you put it in into another context. So you just need to be mindful of what you tweet in the same way that you're kind of mindful of what you say. But it's just something to be aware of, because often we had experiences where we've had sort of like news stories break, and with trusts and universities and all those kind of like bigger institutions, they can't keep up with the speed of information that flies across social media. So if you are caught up in something like that, either don't comment and make a special attempt not to comment, or go to the person in the trust or in the organisation you work for and actually ask to speak to their representative, their media representative, and put together a quote that you can all sign up to. So you can still speak out and you can still say what it is that's important to you, but in a way that is supported by your management and your workplace, and actually represents you properly in a way that you feel comfortable with. So don't get rushed into things, I guess is what I would say.
Yeah.
Vanessa, any advice on speaking up, speaking out?
Yeah, I just totally think what you've just said is really sound advice, because certainly, there are really great journalists out there, and I do speak to journalists, but equally I know that I've been misrepresented at times when I have done things for the media. So it's very easy to be taken out of context. So I think mindful of that, and being able to work with your organisation and being able to think about ahead of the potential of what you're going to say and the context, and also maybe having a bit of curiosity about what kind of article's going to be, what the focus of the article is going to be, because you might think that you're going to talk about one thing, the article might have a very different political focus. And that's the same with radio, because I've done a radio interview and that happened to me on live radio as well, that I was, the focus of it changed when it, so I think it's quite, as a nurse, it's quite a difficult thing to do. I think it's important, and I wouldn't discourage people, but I think what Nick is saying about being cautious and thinking things through carefully and getting support is really important.
And I don't think it's an unreasonable ask to ask the journalist you're talking to, what's the context around the article? Can you just talk me through about what you're writing about? It's completely not an unreasonable ask, and should be questions raised if they won't tell you.
I mean, I do that, but if somebody is kind of speaking to a journalist for the first time, they may not have that experience to know what might happen with that. So I don't want to seem negative, because I do think, given what we were saying earlier, it is important that we do speak out and that we do talk about our profession and kind of moving forward mental health and raising inequalities. But equally, we've got to do it within a professional context and framework as well, I think.
I think the other thing is you don't even have to be saying anything that controversial. What I love is, when I first started out, people came up to me and said, "Are you a mental health nurse?" And I was like, "No, what's a mental health nurse?" And then I found mental health nurses, and I knew absolutely I was a mental health nurse. It was just so nice to be around that culture. I loved it. I still love it. And that's what I'd love to see more of. I mean, nurses don't need to be, forever going to the barricades and complaining. It's even just sharing the kind of positive stuff that we do, who we are, what we care about, the fact that there's tons of different kinds of ways to be a nurse. You don't have to be a nurse in one particular way. We've got tons of different voices, and also being really clear about the fact that there's an artificial separation between service users and staff sometimes. People can be both.
Yeah.
It's not one or the other. Being a nurse is not a discrete thing. You're a nurse and a person and a brother or a sister or a mom and a citizen, and those things all really connect up together. So I would just like to hear more nurse voices and people being able to be confident to say, actually, the skills that you have as a nurse, being practical, being pragmatic, being able to weigh evidence, being able to critically make critical decisions, those are key skills for society, particularly at this time. And I think one of the things that maybe social media is going to give us is the ability to create our own terms of conversation. So when you see a Twitter chat, it's completely egalitarian, isn't it? Anyone can join in. When you see a blog, anyone can write about something they care about or review a book that they care about and send it in. And there's lots of ways that you can participate in a conversation without it being something that's aggressive or frightening for you.
Yeah.
So I think don't be discouraged. We're nearly at the end, though. So can I just ask you, as we're rambling on, is there anything we can do to move forward? So I think everyone's rightly said, COVID has brought us challenges, concerns, lots more questions than answers. But is there anything sort of positive that we can take forward, or anything we need to particularly bring to the forefront? What do you think, Rebecca?
I think so. There have been a lot of positives that have come out as a byproduct. A lot of transformational changes that services have just made overnight. So I don't know, for example, the flexible working, allowing our workforce to work much more flexibly, and thinking about how we hold on to that actually when in a year's time, hopefully that this is over, or so thinking about how you can keep hold of the transformational changes that have happened in your service and perhaps sharing them more, because as you said, we're I think NHS services aren't great at sharing best practice and good things they do.
Thank you very much. Nessa?
Just the way that it's raised the profile of what we do massively, I think, amongst the public, and that kind of awareness of the value of nursing and nurses and doctors and other healthcare professionals. And, for me, I agree with everything that Rebecca said about innovation, but for me, it is about changing the perception of nurses and how we capitalise on that post-COVID-19 and take that forward is really important. But I think that's a positive for me.
Is there anything else coming out on social media?
No, I think it's quietened down really on social media. We haven't had any more comments. Okay. Quite a few people listening, and I guess I'd just say, if you, as we're about to finish, but if you comment further, do comment on the hashtag, and we'll keep an eye on that, and we'll be able to refer any kind of comment and further questions to Rebecca as well, who's on Twitter. So, just contact us via the hashtag.
I guess all that remains then is to say goodnight, and thank you very much, everybody. It's been lovely to see you again, and thank you for Rebecca for coming and joining us today.
Thank you both for having me. Okay. Bye.
Bye-bye.